So with that, I'm very pleased to introduce Dr. La Piana to cover our final substantive talk of the day around transfer to adult care.
Thank you for inviting me. Let me just, okay, I think I have it. So thank you very much for the invitation. I really thank you, the Yaya Foundation. I really thank you, Genevieve, for inviting me here to present. I'm happy and honored to be here because I really value a lot the synergistic work of clinicians, scientists, and patients associations and families. So I will present today on the transfer to adult care. Just a brief note about myself. My background is in pediatric neurology, so I'm a pediatrician by background, but I now work in the adult setting with adult subjects. So I know a little bit about the two different words, and I will welcome any questions at the end. So these are my disclosures. These are the grant and the research support I have. But I think we need to start with a general background, a general introduction to this topic, because among the patients, among the teenagers with chronic health conditions, and of course, among these, there are patients with leukodystrophies, we know that 8 to 10% of them require ongoing care into adulthood. This 8 to 10% is expected to increase, and is already known to increase, thanks to the improvement in the quality of care and in the increased survival. Specifically for leukodystrophies, what does that mean, increased survival? Well, historically, what we know is that what it is written in the literature is that the neonatal and infantile forms of leukodystrophies were expected to have a very short life. And a longer survival was only seen in later onset forms. Let's say patients that had an onset at least around the age of 10 and older. But this is what we knew years ago. Actually, now, every time we diagnose a patient, we know that their life expectancy is actually a bit longer than what we used to tell families. And this is due mainly to the improved clinical care. And as you witnessed today, to the importance that we have given and that we have increased in giving to the multidisciplinary approach. This is key, this is crucial. You have heard that from all the speakers today, and actually it pays off because it results in a definitely improved clinical care and increased life expectancy. The second reason why there is a longer survival of patients is because that's not the case, unfortunately, yet for 4H syndrome, but there are new treatment options available, and hopefully there will be for all leukodystrophies in the future, such as, for example, hematopoietic stem cell transplant for some forms of leukodystrophies. And this, again, has contributed to an increased life expectancies. There is another reason why we see more patients transiting to the adult care, patients with leukodystrophy, and this is due to the fact that we have now the availability of genetic techniques, diagnostic techniques that have allowed us to recognize and to diagnose patients with milder forms of leukodystrophies and with later onset forms. So all these factors that I mentioned to you contribute to the fact that there is an increasing number of patients that are actually with leukodystrophy that are actually now treated by adult neurologists and adult specialists. But let's go a bit more into details with the 4-H leukodystrophy. Of course, it is considered, and it is a prevalent disorder of the pediatric population, but from the data that we have from the paper published by Dr. Wolf and Dr. Bernard in 2014 on neurology, if we look at them, we see that the age at the time of that study for all patients included patients as old as 40 years old. And the median age was actually 18 years old, which you see is already borderline with the adult population. And if we look at the type of investigation that have been analyzed for that work, for that study, the age at the last MRI, so still a diagnostic investigation, ranged between 15 months and 39 years old. So this to say that, yes, 4-H patients can be adult, become adult, and we need to approach this, keeping this in mind. There are other factors that I think we need to consider in this, talking about the transfer to adult care. And it is the fact that even talking about the clinical symptoms and the evolution of the disease over the years has some specificities for older and adult patients. For example, it seems that spasticity present later on during the disease course. And also we know that the mean age at onset, at when patients start using a wheelchair is around the age of 14. Even though half of adult patients can still walk independently somehow. Also, another important factor is that, for example, cognitive deterioration occurs later on during the disease course, approximately during or after the second decade. And we also know that the patients presenting after the age of 10 are at least 10%. So 1 out of 10 of all the patients with 4-H leukodystrophy present when he's a teenager. And this is probably underestimated. And for the reason I mentioned to you at the beginning of this presentation, we are seeing more and more patients presenting later on in their childhood and early adulthood. So 4-H leukodystrophy in older patients can present with milder forms and with some symptoms that sometimes seem to be specific or at least, if not specific, more prevalent in this age group. For example, movement disorders or attention and concentration deficit. We have recently seen a patient who was 24 years old. The diagnosis was made at that age, and she presented mainly with attention deficit disorder. That was the symptom of presentation. So we really need adult neurologists and pediatric neurologists to work together to better understand the entire clinical spectrum of this disease, to promptly diagnose and taking care of patients with 4-H syndrome. So why it is important to talk about the transition to adult care for patients with 4-H leukodystrophy? Well, the main reason that I think I explained to you is that these patients have evolving needs and evolving clinical pictures. And due to this, both patients and their families or caregivers really need to familiarize with the idea of transfer to adult care early on, and the sooner the better, so we can put in place a system that facilitates the transition, which we need to avoid being abrupt in any way. So the aim of the transfer to adult care is to improve the young adult skills to navigate in a system which is different from the one that you see in the pediatric setting, to minimize the secondary illness, to plan for long-term needs. And I really like that this talk has been, is following right after the palliative care, because that's a type of conversation that need to be put in place together with the transition to the adult care. And to promote autonomy of the patient, because of course the adult system is more centered on the patient themselves, instead on the rather than on the caregivers. Okay, these were the aims, but what is the evidence? Well, the evidence, unfortunately, is that in many centers, there is not yet, let me say yet, a transition program in place, or at least some policies that, that help organize the transition. And consequently, patients often, unfortunately, experience an abrupt transfer. And for many patients, especially those with a complex picture and many special needs, may receive an insufficient and late transition planning that then brings complications. That's one possibility. The other possibility is that we observe, and which is not ideal, is that in 11% of cases, what we see is that adult patients still remain under the pediatric care throughout their lives. Why am I saying that this is not ideal? Because of course, an adult subject and even an aging subject will be more appropriately managed and taken care of in adult medicine settings. So that should be our goal. The end result of this evidence that we know from the real life world is that there is a decrease in the annual rate of visits to specialists, and conversely, an increased annual rate of visits to the emergency department. So which are the problems that prevent a successful transfer? Well, the first are definitely in the care system. Because there are big differences between the two systems, because there are long waiting lists, and in some countries, I know there are people in this audience, there are families from all around the world, so we have very, very different situations, and I know because I'm Italian by origin, so I'm familiar with different health systems. In some countries, there can be problems of insurance coverage that need to be addressed promptly. But there are also some barriers that belong specifically to physicians. As I mentioned already, there can be a lack of familiarity with the transition process. Another problem is that still sometimes adult neurologists are poorly familiar with genetic leukoencephalopathies such as 4H syndrome. Psychologically speaking, we also notice sometimes that child neurologists tend to be excessively protective. We tend to be quite maternal and sometimes even paternalistic. And that's a factor that can impact and affect a successful transfer. But I would say that one of the major problems is anyway the inadequate communication between the two systems. There are also some factors that are specific to the patient and the families that can produce a resistance to a transfer to the adult care. And one of these is the attachment to the pediatric team, especially when a diagnosis has been made in that setting by those specialists. They know, they will know the patient and the family so well that separating from them, it can be very hard. Therefore, that can be a difficulty in accepting the transition and to adapt to a less paternalistic system. And I know it by experience because, as I mentioned to you, I'm a pediatric neurologist by background. When I started working with adults, it looked to me that there was not that close relationship with the family and the patient, but actually it was really because the relation is more centered on facilitating the autonomy of the patient and the caregivers. So all these can lead to a lack of adherence to follow-up recommendations. There has been a very interesting study published recently in a few months ago in 2022 about the patient perspective, and I'm really interested by the patient perspective in all this. And they interviewed a cohort of 100 patients with rare neurological diseases who transitioned to the adult care, and 52% of them were informed about the transfer to adult care around the 18th birthday. This is definitely too late. And we will see why. I saw already that in the chat there were questions about what's the age in which this should start, and I will definitely talk about that in a minute. Very interestingly, more than 90%, so basically the totality of the patients and families interviewed, considered very important two aspects. One is the fact that the entire medical file, and you know that the medical chart of patients with 4H syndrome can be quite important, should be transferred to the adult sector promptly, not after the transfer occurred, but before. The second thing that was considered essential was, if possible, a joint consultation with pediatrician and adult unit physician, ideally more than one. There are guidelines that we can follow to organize this transition. All guidelines agree that the child neurologist has a central role, both in the planning of the transfer and in coordinating it. So let's talk about the timeline. And again, since some of you have already asked the question. So the topic ideally should be introduced with the family and the patient around the age of 13. Not only to get familiar with the idea, but also to start all the assessments that are determined to see how the patient can self-manage his or their situation, even when it's limited, and if there is no autonomy in cases of severe encephalopathy or very complex clinical picture, the attention should be put on the caregiver's ability to manage evolving care demands. And we need to keep in mind not only the evolution of the patient, but also the aging of the caregiver themselves. So these are all factors that need to be brought to the conversation early on. More or less 1 year later, we should start discussing the legal guardianship and start preparing a transition plan with regards to the primary care, the legal aspect, the school, the housing, because we need to keep in mind that a patient turning 18 will face big changes, not just in the clinical care, but in other aspects of his life, of their life, such as education, such as housing, such as legal aspects. So the preparation of the transfer package, which is big and requires time and work, should ideally start around the age of 15, 16. These include, besides the obvious summary of all the healthcare issues, all the treatment and trials that the patient underwent throughout his life, any past procedures and how they respond to that, the participation in research protocol, all the studies the patient is still on, the emergency plans, very important, and also the patient's and the family advanced plan of care, including the living will, the resuscitated, do not resuscitate order, and so forth and so on. So the identification of the adult provider should be done not later than at the age of 16. Why this? Because ideally the transfer of the package of all the medical chart should be done at that stage. It's only in this way that the adult setting can really evaluate how to put in place already all for example, the multidisciplinary approach that this patient needs. It takes time. We should work really timely. And that's where we go to the joint pediatric adult transition clinics. We shouldn't wait ideally until the age of 18. They should be done before. At the age of 17 is fine. It will still leave 1 year or more to adjust to the transition. Joint clinics are perfect to facilitate this and to make everything smooth. And then at the age of 18, the transfer should be completed. And the pediatric neurologist is responsible for verifying that the transfer has been successful. Is not a person that disappears. Of course, you know, those of you who has adult family members, affected family members, know that the pediatric neurologist will not disappear from one day to the other. They are there, they verify that everything has been done correctly. They remain available to guarantee that this transfer is taking place in the best way possible. And with this, I conclude. I leave space for the questions and for the discussion. The two main points that I would like you to bring home are first that we work as a team, pediatric and adult specialists, to improve as much as possible the rapid identification of patients and identification of their symptoms and need, to really help identifying and characterizing adult patients. And the collaboration is even more important in the transfer of care. And having said that, really, I'm done. I think again the Yaya Foundation, Dr. Bernard, all the team that has organized this event, my lab, and I like to conclude with this quote by the writer Paulo Coelho, who said, "If you're brave to say goodbye, life will reward you with a hello." And thank you.